All right. Hey, everybody. Thanks for joining us. As usual, my name's Dusty. I'm the VP of Marketing here at VitalWare, and I get to introduce our wonderful speaker today. Today's webinar is Denials Management, Case Studies in Best Practice. And as usual, we really appreciate you joining us. As we all know, you are very busy, and we've had a busy week of webinars this week. So if anybody's made all 3 webinars this week, we really appreciate it. And hopefully you've learned a couple things this week. As usual, again, before we start, I'm going to cover the housekeeping items, which is mostly that you are all on mute so that we eliminate all the background noise that could happen otherwise. But we do encourage you to interact with us and our speaker today through the Q&A panel of the webinar. Please use the Q&A panel and not the chat feature, as if you use the chat feature, we oftentimes miss it. But if you use the Q&A panel, we will not miss it. We will not be answering those questions live today, though, as we do not have the time allowed for that, but we will make sure to answer those questions and follow up and send those to all attendees today. You will also be receiving an AAPC CEU for attending this live. So congrats, appreciate you being here. All right, so on to the presenter. Our presenter today is Lisa Ball, a member of our Revenue Integrity Services team here at VitalWare. Lisa has more than 20 years of experience in healthcare and more than 14 years specializing in coding and documentation. Her experience includes inpatient and outpatient coding and auditing, education and documentation. Her coding experience includes work for the Department of Veteran Affairs as lead coder, coding educator, and physician educator, Medicare auditor, HCC auditor, and DRG validation and insurance auditing. And Lisa has her Bachelor of Science degree in Health Information Management and is working toward a Registered Health Information Administrator credential. She is a certified coding specialist and a clinical documentation improvement practitioner. Her experience extends into denials and clinical documentation for rebuttal and appeal review processes. So to sum it all up, in other words, she is more than qualified to give the presentation today. So Lisa, I'm going to hand it over to you.
Thanks, Dusty. I appreciate the intro. And thanks everybody for joining us today. Like Dusty said, we know that everybody's time is valuable, and we all have things that we have to get done every day. But getting our CEUs is just one more of those tasks that we have to complete. So definitely it's good for you guys. We love to give these presentations with free CEUs because we know that everybody has a ton to get, and paying for each one individually can add up. So we like to give that service out there. So we're going to start off with our disclaimer statement, and I'm not going to read through this, but it just pretty much lets you know that as of today for the presentation, everything that we've put in the slides is up to date. But definitely we always like to tell our attendees that we encourage you to, in addition to whatever we present, to still check your guidelines and your materials as necessary. So our agenda for today's call, we're going to go over what denials is, trends from 2019 that we noted during some of our reviews, examples of those denials and rebuttals that we've worked on, as well as the process behind denials management and building a team. So this slide just shows each section within our presentation today, what to expect. And then I just threw a little bit of humor in to our presentation because a lot of what we look at is pretty dry and can get a little bit of a burden. But, we work hard in our industry. It just kind of seems like sometimes that we're inundated with these denials and that the insurance companies just might be in denial about needing to pay the claim. So we're going to start off with a quick overview of denials management. This might be a little bit redundant for some, but it is necessary in staying relevant to a wide range of attendees that might be at a different stage in their career and in the denial process itself. So we will move on later in the webinar with examples that will be better suited for more of our seasoned attendees. So just a notation of what denials management is defined as. And this is kind of a hodgepodge of my own version that I've adapted from different definitions that's out there. So for denials management, we must understand why a claim is denied, how to reduce future denials through the creation of better processes and policies as a best practice so that we get accurate and solid reimbursement. So who will make up a denials management team? This is going to include a really robust team, such as staff from your admissions area, case management, utilization review members, financial services, clinical documentation improvement staff, the HIMSS department, information technology department, your chief financial officer, compliance, contracting, and your hospitalists or physician advisors for those peer-to-peer reviews. For larger facilities or large provider groups, it is advisable to establish several layers of teams. A typical hierarchy would resemble a pyramid. And at the top would be the leadership or steering committee with executive and senior level members in that group. And these team members will be presented with your denial statistics, and they'll make or approve recommendations for your denials management team. So at the very top of this pyramid would be the compliance officer and physician chief of staff. The physician advisor would likely sit at this level, but may also attend your working meetings at a lower level too. The second layer would consist of managers or directors of the different departments driving the denials management initiatives. And this would be considered your working group. And here they're going to vet out the data supplied by the teams, and they're going to identify the root causes and proposing solutions for that executive team to review later. The entire process would, of course, start at the beginning with that working team working through the denials within your organization. And they may not sit on either of the two official denial committees or teams. This group consists of key staff from your case management or the denials and appeals unit, your business office, coding, and medical records. Each department's going to bring its own specialized knowledge to the denials process in prevention. And so here is a few examples for each of those areas we've listed out in this slide in the next few. You know, in the admissions registration area, they're going to be dealing with those incorrect plan or ID numbers. They're going to be verifying the benefits and doing pre-authorization and dealing with those issues. Your case management and UR members, they're going to look at length of stay and getting approval for that, level of care, and then the appropriateness of the services being rendered. Your financial services are going to deal with those billing edits, submission issues, and timely filing. Your CDI staff, they're going to be reviewing denials that have clinical picture ambiguity or denials between what the clinical validation should be for a diagnosis and for medical necessity and the relevance. And they're going to also work with educating providers for that appropriate documentation. Your HIMSS department are going to work on those DRG evaluations where there might be errors in coding with the principal diagnosis or the procedure coding or even both. And they're going to respond to denials based on those coding issues. The IT department, they're going to help with tracking, getting that set up for your trend analysis. They're going to set up alerts for providers to aid in documentation needs to avoid future denials. And they're going to help you with your routing for your denials as they come in. The CFO, they're a great asset for gaining that executive leadership role and support. And they have an invested interest in the financial impact of your denials from what the baseline is or expected for your facility to get in reimbursement. Compliance, they're just going to ensure the overall compliance within your denials process, how the information is requested, released, the documentation, and your corporate compliance. Hospitalists and physician advisors, as mentioned before, they're going to help with those peer-to-peer reviews in those higher up levels of denials in your appeals. And they're going to also help with that education, sending it throughout the organization with their peers. And lastly, but not last, the contracting department. They are a huge asset in investigating the contracts for possible revisions and to better understand what is actually covered through that payer. And they can help to negotiate future contracts in favor of the patient and the facility for their coverage needs. And additionally, each department needs to understand where their denials are coming from and how they're being routed, if they're electronic, mail, email, fax, and getting that into a better process, more consistent within the organization. So the core frontline team would consist of your admissions and registration staff, case management, the financial services, CDI, HIMSS, and at times your hospitalists and your physician advisor. So the ultimate goal of a denials management team is to receive the most appropriate payment by recouping or recovering the lost revenue, and then preventing future struggles through claims analytics, and then learning each payer's appeals process and trends to work claims through to the final payment. And this may be where people have to be divided up within that working group that they specialize with a certain payer so that they can learn those trends. And lastly, for this section, we wanted to make note that Healthcare Financial Management Association, HFMA, they did an analysis a few years ago on denials management, and they had noted that in their analysis, the gross charges denied by payers is close to 15 and as much as 20% of all claims submitted. So can you imagine the impact that this could have on a facility with 20% of their claims being denied or needing reworked? And not to mention the potential loss in revenue per claim and overall, but also the loss in revenue generated from reworking those claims through the rebuttals and audits that are being performed. So then they further estimated that out to be another $25 per claim for that. And with the possibility that facilities aren't checking all claims, that there's about 65% that probably don't get looked at. And due to that assumption that, close to 70% of claims aren't being reviewed, that could be another 3% of lost revenue overall. So it just adds up and just justifies that need for prevention and the whole denials management process. So we're heading to our next section for denials management and setting up a best practice, the process and structure. So steps are involved in setting up your process. First, you're going to need to analyze your current process to see what works and what doesn't. Understanding where all denials trickle in matters. This will help expedite the process and streamline how things are received. What needs to be improved in this stage of the process, utilizing that steering committee and your leadership staff and your frontline staff to help map out the process and create your procedures and policies that fit your organization and that looks at the entire workflow of the facility, and also that drills down to the individual roles and functions. So you may want to divide your teams up by their department and then further by their roles and figure out the best ways to communicate between each of the teams that doesn't hinder your denial process or add to your timeline. You're going to need to determine how to categorize denials and how to route your procedures to expedite that rebuttal process, and then look at follow-up protocols in handling a rebuttal, those ones that's already been sent out, and the appeals and the peer-to-peer reviews that you're sending, and how to track the entire process in order to trend which parts of your process are creating improvement and helping with prevention. If you have enough staff, then as I mentioned earlier, you would want to specialize by a specific payer to help with this. So this helps with the consistency, and the staff can learn the denial process within each payer and gain that insight. Make sure that you categorize your denials by root cause. This helps with your trending. And it also helps with how you assign your resources for better overturns and to expedite the whole process. Facilities may choose to send a majority of their denials to the HIMSS department with the initial thought that it might be a coding error. And you know, that might be true in a lot of instances, but it's not the case every time. Some denials may need clinical review, such as a sepsis or an acute respiratory failure for their validation within the clinical picture. And that would need to go on to CDI or even a physician reviewer. So by sending those denials to the wrong department, it's just a waste of time. It's going to end up in being rerouted, and it may even get misplaced or lost and not referred back to in time for an appeal. Denial sorting and team creation can help with your overall turnaround time, and it can shorten that payment timeline for your facility and increase your overturn rates and reduce future denials. And not to mention, it also just helps with consistency and better outcomes because, you know, your staff's not getting so frustrated with the whole denial process. All right, so the denial and rebuttal process, we'll look at what your rights are and how a denial is processed in this section, and then we'll move on to those examples that I mentioned. So the appeals process varies by each insurance company, and they may have their own proprietary way to start the appeals process. So it's important to fully understand the time frame allowed for your rebuttal, the necessary documents, and the proper submission address to the payer, which that can vary depending on the type of denial. An appeal is very time consuming, so it's important to be organized and respond as quickly as possible. So staff should become familiar with the details of each individual payer in order to manage the appeals process. There could be proprietary forms that they want submitted. There's their own timely filing constraints and the different levels of the appeal for each. So an example, Medicare requires that you send in a redetermination form for a first level appeal. If the denial is upheld, there is a second level appeal form called the reconsideration form. Each step in this process is mailed to a different location. So Medicare, for their appeals, the rebuttal must be filed within 120 days of receipt of their remittance. For a second level appeal, you have 180 days from the date of receipt of the redetermination decision to file a reconsideration request. Each step has its own form that needs to be filled out and signed by the person sending it back, along with the medical records if you're trying to support medical necessity. So just right there, you know, the different time frames with just Medicare alone, regardless of other payers, is why it's good to have staff specialize in a specific payer to learn and get familiar with all those processes. You have rights as a facility and as an insured individual to request reconsideration under the Affordable Care Act when treatment is denied. You have the legal right to ask for an internal review. If this appeal is denied, you have the legal right to ask for an independent external review. So just know that you have the rights to a redetermination, an internal and external review, peer-to-peer review, and an appeal. When responding to a denial letter, you need to include key information to support the denial and to avoid further complications in the whole process. You know, include the date of the original denial. And some of this is going to seem redundant or a bit over the top, but as you'll see through some of our examples, payers can deny for some of the strangest things or not fully understand your write-up and your rebuttal and back for just a miscommunication. So you're going to want to include and reiterate even your denial reason or denial rationale. List out your codes, their description, and how it affects the reimbursement or in an inpatient case, the MSDRG or the APR-DRG. State your stance. Again, that sounds funny, but we've seen denials where they cannot tell whether it's an agreement or a disagreement. Back your determination with clinical facts and solid references. You know, cite your sources. Rewrite the references and guidance and list them so that they don't have to reference them themselves. Note areas that are inconsistent in their argument. And also enlist help from your provider for that validity. And ensure that you have the appropriate contact information to avoid delays. You know, follow-up calls are great as well to clarify that information. Avoid common errors that may cause payers to deny a rebuttal, such as, you know, not signing that rebuttal redetermination, not including your documentation. You know, here's an example of some verbiage submitted by a payer with the denial being stated as due to a lack of verbiage for agreement or disagreement, as we mentioned earlier. You know, it seems so simple and implied, but by noting your stance, the review process just goes so much smoother and avoids those additional problems with a miscommunication. So a good starting point to any denial management is looking back and tracking who has been denying the most and what's being denied and who's affected by that denial. You know, is it a provider documentation? Is it a DRG variance due to a coding issue? You need to know the number of denials. What is the highest one? So this helps to figure out what you have been successful with so far for overturning your denials and what has been upheld and what's not working and still needs to be addressed. It's also good to find out the overall cost of these denials, and that's a great point in knowing where you've been, engaging the success of your team in its efforts moving forward. And it can also help with those staffing needs later on as well. Additional areas for denials prevention include sharing knowledge with your facility stakeholders, like in those team meetings mentioned previously. And then also being informed with your regulations like the IPPS rule, the OIG work plan, your RAC target areas in order to move from avoidance and dealing with things after the fact to prevention. Tracking denials for realizing your turnaround time by payer to improve rebuttal process and to determine what has been overturned, what the actual payment was, and your win percentages. These all need to be tracked by both volume and percentages in order to move closer to that prevention and improvement overall. You know, you're going to want to know the appeal type and patient type, number of denials, the denied claim and number of denied claims, number of appeals per claim, number of paid claims, no denial in comparison with one another. A payer denial rate, how many denials are you getting for that payer? Your variance with the expected payment. So what did you recoup versus what you expected to recoup? And you know, similar, the payment post appeal, you know, if it was overturned, what you were able to maintain. Now moving on to our last section where we go over trends and examples of denials and those case studies. So in this slide, you're going to see MDRGs that we noticed insurance companies focused on in 2019 that related, and all of these, they related to a claim with a CC or MCC for their placement and payment. So in general, these were claims that had one CC or one MCC on them, and the insurance company was targeting that secondary diagnosis for removal from the claim to reduce the payment. We even see instances where a claim may have several CCs, but they only have one MCC, and then they'll end up targeting that one MCC to try and reduce payment as well. So this slide is a continuation of the previous one. However, there is a little variance in it. Here we show some DRGs that are not necessarily based on just whether it has a CC or an MCC, and could be based on the principal diagnosis selection, or both the principal diagnosis selection and the procedure selection, such as those 980 DRGs. As a basic overview, payers look at those claims with only one CC or MCC. For an example, that could be CHF with pleural effusion, or in the case of one MCC with multiple CCs, an example might be where they're trying to validate the clinical significance of acute respiratory failure or pneumonia. And with procedures, an area that we've seen a lot of denials in is with bronchoscopies, and whether they're diagnostic versus therapeutic. And that would just be a character selection usage within that PCS code that is driving and pulling the weight of the DRG. Now this slide shows an example of the bronchoscopy issue I just mentioned on the previous slide. We've seen in the past that previous grouper versions, such as grouper 33, there was issues with how bronchoscopies were being weighted in the DRG. So knowing the grouper version your facility has on contract with the payer can help with denials management and prevention. Each payer can put in their contract what version of the grouper they're going to use. It may not be 35, it might be 34 or 33. Knowing that is important with your denials as well. Bronchoscopies with that therapeutic versus diagnostic have had an impact in the past, and I believe still does have an impact. In this example, the bronchoscopy was coded with a therapeutic, Z as a 7th character digit instead of X for diagnostic. And so it carried more weight when it went to the payer, and the denial came back with a $4,000 decrease. So just be cognitive of that area within bronchoscopies, and that is something that's definitely preventable. They typically target MSDRG 163 to 168. So if you want to pull those out or educate your coding staff to make sure that those are coded properly, it can prevent with future denials. And this is not one that you're going to be able to overturn. It's going to be a solid denial if it was not reported properly. So we've seen issues with sequencing for the principal diagnosis, such as pulmonary embolisms and hemorrhagic disorders versus a bleed or blood loss anemia as your principal. Sepsis has been an issue for clinical validity. I know that's no surprise to anybody, but it's also being picked when it is a secondary diagnosis with a POA of Y for yes. We're starting to see a lot more POA discrepancies. It's been a bigger area this year than what we would have expected. I'm not sure if there's new coders out there or what might be going on, because we're seeing instances where principal diagnoses have a POA of N on them for no, and that's just not allowed. It's, you know, when you see that, that's definitely something that's going to be pulled by a payer if it wasn't present on admission to be the principal diagnosis. And that is, again, another preventable area. It should not go out on the claim, a principal diagnosis with a POA of no. And then they're going to include that in their algorithms. They're also going to include those sepsises as a secondary with a POA of yes. A few other areas of concern, MSDRG 673, we've seen this one picked for review for clinical significance of acute renal failure in that DRG. MSDRGs 980 are an area that all facilities should look at prior to billing. No claim in the 980 section should ever leave the facility for payment without a review. And 940 is another suspicious DRG to include in reviews that a payer would tend to use in their algorithms for denial claim selection. Here's our review with denial and rebuttal examples. It sometimes appears that payers will attempt to deny just basically anything without any valid cause. Some payers don't justify with clinical indicators their rationale for denying a diagnosis. In this example, the payer states only lack of supporting documentation for the ischemic heart disease as a secondary for this claim. When a payer does this and they don't include that rationale, it really hurts the facility in pulling together what rationale was used by the payer and how to deny the stance on their end. So when you get one like this, a facility needs to include all clinical supported findings to justify the rebuttal and anything that of clinical significance. So here what we've done was we noted the troponin levels for the ischemic heart disease, as well as a linkage made by the provider with the troponin levels and the demand ischemia that was noted in the discharge summary. You're also going to want to make sure that you note the dates of service by the provider and the provider type used in that documentation, or what source was within that medical record that you're using. You know, was it the H&P, discharge summary, and provider type? And you're going to want to also format your rebuttal in an easy to read format that is in a chronological order for them to follow through easily and to notice the care and the treatment process with that disease process. Additionally, you're going to want to list any sources used in the coding decision. And here we were able to overturn this denial by using the clinical indications and coding guidelines. So here we show a scenario where we have 1 cc on the claim. And you know, this is something that all payers tend to target. In this claim, the secondary diagnosis of atelectasis is denied. And so it would shift the MSDRG from 418 to 419. So their denial is valid. They make note that the atelectasis was a normal finding and that there was no intervention needed was mentioned in the documentation by the provider. So there's no stance by this facility for a rebuttal. However, the denial could have been prevented, again, by a secondary review from a coding peer or a DRG analysis prior to billing. And you know, front-end analysis or reviews are so much easier and takes less time to perform on the front end than reviewing these charts on the back end and dealing with the denial process and rebuttal. So in this scenario, we use the same coding guideline as we did in the previous one where we were able to overturn it for that reporting of additional diagnosis, but that was only if it was clinically significant. And so it's not going to work in every case. Each rebuttal stands on its own, has to be written on its own. It's hard to use a template for the nitty-gritty portions of the denial and your sources. So here we have an example of, as mentioned earlier, CHF with pleural effusion. They've suggested removing the secondary diagnosis of J91.8, pleural effusion in other conditions. So scenarios like this would show that the coding department may need additional education on coding pleural effusions. And in this scenario, it adds a CC on the claim, but per that coding clinic second quarter 2015, it notes that to only code pleural effusion when additional work is performed. And a lot of times pleural effusion, it's common with CHF and is usually not treated separately. And that's just another claim scenario that could be used in a payer's algorithms for selecting claims for review to deny. And so that previous scenario, it's continued here on this slide with a response letter to the denial. This is a great example of a possible prevention, again, with a secondary review and having that done prior to billing. There's other diagnoses that could be pulled by the payer in regards to effusion, especially the J90, that's a not elsewhere classified pleural effusion code. It reports as an additional CC on a claim. Well, if it's a claim with only one CC, the payer might look at it, let's go ahead and review it. They are going to assume that there's not available supporting documentation and just send it out for one more denial opportunity. So this slide shows an example of an upheld denial response from the payer. So the initial denial was for a claim with one MCC and no CCs. Although the diagnosis was included in the documentation by the provider, the clinical picture did not support the diagnosis, and this is where coders' hands are tied. If the diagnosis is in the chart and it's throughout, coders have to add the diagnosis. But if the clinical picture does not support it, then we can send a clarification. Depending on the facility, that clarification could be post-discharge. Or, looking at this type of a denial is a great way to educate the physician and the CDI team about the clinical picture and why it's so important, and getting them included in the rebuttal process. However, it's probably not going to be a claim that can be overturned, but it is a learning experience for the whole team to move it into prevention further on down the road, to where CDI can get involved and send a concurrent query to clean up that ambiguous documentation that doesn't fully support that diagnosis on the medical record. Sorry. So this re-rebuttal is a consideration from a prior response to a denial. In this denial, they were denying J9601 for acute respiratory failure with hypoxia as a secondary diagnosis. The initial rebuttal by the facility did not mention full mechanical ventilation. So in the reconsideration, that documentation was added, and it supported the rebuttal. Sometimes just that little verbiage like this can go a long way, and it may seem like going above and beyond or just being very meticulous, but in this scenario, they ended up overturning and paying the claim just for that blip dealing with that acute respiratory failure. So here we have a denial for J69.0 pneumonitis due to food and vomit. And the payer is requesting to change that to J95.4 for chemical pneumonitis due to anesthesia. And they're doing this because that would remove the only MCC on the claim. So again, another example of one MCC. So we were able to overturn this denial by utilizing the clinical indicators. We also mentioned coding guidelines, and we also mentioned how the coding index and tabular worked in this scenario to get to that code for supporting the rebuttal. We noted that the complication was not linked by the provider to the anesthesia, and that aspiration pneumonia was documented throughout the record. And you're going to have all of these slides sent to you, the slide deck. So I don't necessarily read through the entire scenario, but you'll have them for examples to reference back to and review on your own as well. I always think it's helpful to have examples to look at, especially if you're just starting out in this area, just to feel a little bit more confident in what you're sending out and for reference. Here is a continuation of that rebuttal we were just going through, in which we note that the coding guidelines for complications, and then with that relation of cause and effect determination and the index usage. Some instances, denials are upheld and a resolution letter is sent to the facility. So here we show one that was sent for a denial due to multiple diagnosis, meeting the criteria of principal diagnosis. In this response, they upheld the previous denial, and that's basically because multiple diagnoses that meet the criteria of principal diagnosis are very difficult to overturn. A lot of times they're so mutually treated with, you know, each diagnosis has treatment, and it's hard to tell which one is the overriding diagnosis that occasioned that admission. So these are instances where definitely physician advisor help is needed to fight these, because everybody sees it a little bit different, and of course the payer sees it in a way that's going to reduce payment. And you know, as I was saying, in instances where two or more diagnoses equally meet that definition for principal, the payer will more than likely suggest the diagnosis where the reimbursement is much less. So, and then instead of letting your coding department go back and forth with the payer on these types of denials, we suggest that you refer those again to your physician advisor, or even to request it go up to the next level of dispute for that clinical chart validation. Here's an example of another area of concern. They like to pull out hemorrhagic disorders and GI bleeds for denial. This example shows how a payer will argue the principal diagnosis selection in these cases, that diagnosis D6832, when it is the principal. They'll make that part of their algorithm to pull that, and they see a secondary diagnosis of GI bleed or anemia. So like for this one, they had K92.2. So they're going to do that, again, just to get that shifted to a lower payment. We were able to overturn this one. We used in our rebuttal notation of the patient being admitted for anemia, and that they were found to have the bleeding disorder due to their Xarelto. There was additional documentation in the colonoscopy that there was no GI bleed. That was significant to help support our rebuttal. And they also discontinued the Xarelto. That is another huge effect on this chart that showed that the Xarelto was definitely felt to be the link, and the patient received packed red blood cells. Great documentation in this chart to help support your overturn on this one. So this rebuttal was handled by the coding department and was overturned. However, best case scenario would be for the facility to request the case again to be either referred up to that next level of dispute or have the physician advisor help. All right, so here we have a sepsis scenario. No surprise, sepsis has been a big one for a while. And this one, the sepsis was a secondary diagnosis with that POA of Y for yes. In not every scenario, but in most scenarios, the sepsis should be the principal diagnosis per your coding guidelines. I'm not going to read through this denial rationale, but basically this claim was pulled by the payer with the algorithm of the A41.9 as a secondary with a POA of Y for yes. So again, prevention. DRG analysis should have been performed on this claim or similar claims to this for that co-equal with principal diagnosis before ever being billed. You know, keep in mind, especially for CDI staff, however, specifically for sepsis, sepsis does not always equal a higher reimbursement when it's the principal diagnosis. Sometimes when sepsis is the principal, it can lower the reimbursement like it did in this denial. And this was not one that was returned, it was upheld. So sepsis has been a hot target for 2019 with payers' denials for different criteria being used between the facility and the payer, such as if the payer's using sepsis 3 and the facility's using sepsis 2, you know, and not to get into all that, but in general, you know, outside of the ICU, sepsis 2 is the criteria to use. But payers, a few payers have decided that sepsis 3 across the board is what they're going to use, and then the criteria don't match up and the denials start rolling in. So this slide's an example of a denial for sepsis based on clinical validation and criteria with that discrepancy. Most contracts between a payer and facility in the past have not specified or determined what is an acceptable clinical validation criteria for their diagnosis. So for those cases, you can have the provider dispute with their clinical chart validation with those physician advisors for a peer-to-peer. However, you know, in the future, you may want to, well, you're going to want to, depending on the size of your facility and how seriously you want to take prevention, utilizing a team approach with a clinical indicators committee. And this would have your CDI team involved, your hospitalist, your intensivist, as well as your managed care team. And they're going to work together to create a list of clinical criteria for those diagnoses that from your trending reports for denials is showing to be the heavy hitters. And then you're going to use this team and those clinical criteria for each of your diagnoses to help negotiate your contracts with the payers in the future. An agreed upon defined criteria for each of those diagnoses in your contract, especially, you know, like sepsis. So here we have an acute renal failure example. This one is denying the acute renal failure as the principal and is wanting the I-13 to hypertensive CKD code to be used as the principal. And that's just kind of amazing that that's their argument. It was able to be overturned. So in the rebuttal, we noted the disagreement and the documentation was great. The provider noted a baseline creatinine with a major elevation from 4.4 to 13.9. Definitely an AKI. Although the patient has hypertension and CKD, this is an acute injury, exacerbation. It's in addition to, this is acute on chronic CKD. And so that I-13 range does not include the AKI. And so the AKI would be coded as well. And this patient was admitted for it, stabilized, and the care was focused on it. So we were able to overturn that rebuttal. So lastly, we have an example of a 980 series MSDRG. In this denial, they're requesting a change in the procedure code based on a drainage of the spinal canal. So this is our last slide before we wrap up. And you know, you always want to check your 980s, you know, definitely as a facility, but we listed this example because it really shows why contracting is so important. I mentioned earlier about, you know, helping and getting those contracts reviewed for your clinical indications, but also we had mentioned earlier about the different versions of the grouper and how they can affect. Well, with every version, there is changes to the grouper, and it affects what, you know, goes to where in the whole MSDRG or APR-DRG realm. So for MSDRG version, okay, so let me step back. So for this case, this denial was sent to the coding department. The coding department reviews it. They agree with all the codes that the payer is saying. But when they run it through the grouper, they don't get the same MSDRG that the payer is getting. They're getting a 980 and the payer is getting a 193. After they change their codes, that's what they're getting. So they get confused on the whole, you know, what's going on. We've changed the code and we're still maintaining our DRG. They ended up getting a hold of the contracting department and found that the payer was not using version 35 like the coders was using. They had agreed upon in their contract to use version 33. So a lot of wasted time was used reviewing this claim after the fact of changing the codes. You know, the rebuttal was, or the denial was upheld. There was no rebuttal to be able to be had, but there was lost time with reviewing it after the fact and trying to figure out what was going on with that claim. So definitely include your contracting department in your processes. And if you're a coder and you get something and it doesn't jive, you've made the changes, you agree, definitely it should hit you, if you don't already know, to check with your contracting department to see what version of the grouper they may be utilizing. So that wraps up our denials management call. I've got, the next slide just has some resources on it. And again, I just wanted to remind you that we're not doing live Q&A right now, but definitely submit any questions that you have in the Q&A area, and within 7 business days of our presentation, we'll get those back out to everybody who's attended. Back to you, Dusty.
Perfect, thanks, Lisa. As Lisa mentioned, we're not doing live Q&A, but I will stay on for a few more minutes. If anybody has any questions, just put them in the Q&A panel. We'll make sure they get all answered. If you want to stay in touch with us in future webinars or articles or different resources, again, the best places to do that are to either follow us on your favorite social channel like LinkedIn or Facebook, or to sign up for our monthly newsletter called The Mid at the footer of any page at vitalware.com. Thanks again for attending today. We will be emailing out your AAPC CEU to those that attended live, as well as where to find the presentation and recording.